So we're moving on the types of venomous snakes in Malaysia, which comprise of land and sea. So there are several, just as what I mentioned before. Basically, there are two types of family that are medically important around the globe, which is the Vipridae and also the Elapidae. Same goes to Malaysia. Basically, all family member of all family members of Elapidae and Vipridae in Malaysia are medically important. And then there are few in family in Nitricidae lah, which are potentially dangerous to human when get bitten. So for Elapides, basically example is a cobra, crate, and as well as a coral snakes. And for the Vipridae, as the name suggests, it belongs to a viper's family species. And for the Nitricidae, it's basically a red-billed keelback. So basically, we have the snakes, there are five lah basically, which is comprised of cobra, kicking cobra, crate, coral, and also the sea snakes. So bear in mind, you can see all the local names there. So easy for you to understand, and as well is the local effect and the systemic effect. So on your right side, basically the few pictures, okay, few pictures of the snakes that we have. Okay. So on top of that is basically a cobra lah, okay, of Ophiophagus hana. Synonym we call it the king cobra. And then as the second top is basically a crate, okay. And same and from the last one is basically a coral snake, okay. So basically this is the venomous snakes from the Vipridae group lah, basically. So this is from the Peninsula Malaysia itself. So you have a look at, basically they have four types of genus, okay, with together as well with the local names. Okay, just now we talked about the previous species it can be found in the Peninsula Malaysia. Now this is the what you call the species that you can find basically in Sabah and Sarawak. So okay, this is the Nitricidae. So Nitricidae basically there's only few species lah. There's a few species families that are potentially dangerous lah, which can cause significant probability. Among of it is the red neck keelback lah, basically, or the name is Rhabdophis subminetus. But most of the Nitricidae family does not cause harm to the human. Only this one we found it can potentially can cause significant coagulopathy. Okay, so for recommendations of for early interventions following snake-related injury, land and disease. So basically, the early recommendations for the snake-related injury is for the victim to identify the kind of snake that's okay. Okay, and then this is important because that's what we showed just now. The mainstay of the treatment is envenomizations, and these envenomizations basically must according to the species itself. And then the second recommendation for early intervention is basically immobilizations of the bitten area and keeping the victim still. This is important because we don't want the poison. Sorry, we don't want the what we call the venoms to be spread faster. So that's why the idea is to keep the patients, the victims still, calm, and basically, yeah, basically. And also immediate visits to the nearest ED. Okay. And there are few things that the victims or the people's or the first responder should not do, which is pick up the snake and trap it. Okay. So a big no. And also never wait for the symptoms to appear. Okay. Just go straight to the ED once you've been bitten. Okay. And then do not apply tourniquet. Okay, because previously this was the practice that we always saw in the TV when someone get bitten, they apply the tourniquet, but then specifically it's a contraindicator. Basically, we don't want to stop the blood supplies to the area of the bitten. Okay, so basically do not apply tourniquet. And as well, try not to suck out the venoms, okay, or slash the wound with knife or put anything to the bitten area. So this is a big no that one should never do. Okay. Okay, so basically the principle of treatment. Okay, so once the patients arrive to the ED, the first thing the patient has to do is the triage basically. So once must triage the patients, okay, with possible systemic and local envenomizations to the critical operation. So, but then still the asymptomatic patients should be managed in semi-critical, especially or in other words, okay. And then a rapid clinical assessment should we do. So the goal of the primary assessment is basically to identify any life-threatening so resuscitations must be initiated immediately upon recognitions. So basically we have the A, B, C, D, E. So airway must be patencies, the breathing efforts, okay? Look for any poor respiratory efforts in the as for the circulations, looks for the evidence of shocks and bleedings. And as for the disability, look for the disability of the nervous system, the conscious levels, the muscle weakness, and as well as the exposures and the environmental conditions. So primary assessment must be complete, okay, to to identify basically to identify any lack of tracking. Okay, now we move to the resuscitation. Okay, still can hurt some. So resuscitations basically to the first is to optimize airway patencies. So to perform head to chin lift maneuvers with the adequate suctionings. So depending on the patient's conscious levels, the patients can be put in a left lateral position, supine or prop patient. Okay, this is to ensure the airway is maintained and adequate. So if the oxygenation does not work, so supplementation is a must. So appropriate delivery device as indicated. Okay, and can consider also inserting the oropharyngeal airway to aid in the airway patency. Okay, do not attempt this. Okay, if the gag reflex is still present. Okay, uh, so resuscitation is a must lah because there are few venoms group which is the neurotoxic group which can lead to paralysis of the respiratory muscles and cause respiratory failure. So in the case of that, NIV support, okay, via NIV support is might be required lah, and then followed by the definitive airway insufflations when indicated. Okay, for move to the circulations part, the when profound hypotension and shocks can be due, okay, to the direct can be due to the direct cardiovascular effect of the venoms or secondary effect such as the hypovolemia, which result from the release of the inflammatory vasoactive mediator and hemorrhagic shocks. Okay. In skeletal muscle breakdowns, which is the case of rhabdomyolysis, hyperkalemia also can cause a cardiac arrest. So CPS should be initiated if the patient is in cardiac arrest. Okay. And basically, at least 2 large bore IV cannula should be inserted with appropriate fluid resuscitations. And at the same time, look for any source of external bleeding and apply appropriate methods for the bleeding control. And then cardiac monitoring is a must for case of arrhythmia, and management shall be according to the advanced life support management. So basically, close serial monitoring of the blood pressures, basically vital sign, heart rate, respiratory rate, and SpO2 is a mandatory. Okay, for every 5 to 15 minutes in an acute stage. Okay, and use of snack bite chart is the convenience, and also the monitor urine output hourly. Okay, and also note the color changes of the urines, especially in the snake bites, because basically they can cause a rhabdomyolysis. So which in turn can cause a dark urine color.
Thank you, Adnan. So now I will continue with indication for antivenom. Clinically, the presentation of envenom patients is often complex, and antivenom treatment should be given as soon as it is indicated. So, because antivenom treatment can often reverse the systemic envenoming, even if the symptoms has been persistent for a few weeks. And the antivenom treatment is recommended if the patient is proven or suspected snake bite developed with one or more of the following signs. So the sign can be divided into two categories, which are the systemic envenoming and the local envenoming. I will start with the systemic envenoming. So the systemic envenoming, the first one I will be talking about is the hemostatic abnormalities. So by saying hemostatic anomalies, so we need to see, when we see patient, we need to find out if there's any spontaneous systemic bleeding, for example, bleeding from the bite side, or spontaneous bleeding like patient coughing out blood, hemoptysis, or any hematuria. And besides the clinical parts, we also need to monitor the laboratory like FBC, like any coagulopathy, any thrombocytopenia. And next, we'll look for any neurotoxic signs. The neurotoxic signs, for example, topsis and external ophthalmoplegia that we can see from this picture here. This gentleman is having a ptosis after a snake bite, and normally, when a patient is bitten by elapids, for example, cobra, krit, or coral snake or sea snake, they will exhibit these neurotoxic signs. So they were having this paralysis of the extraocular eye muscle or dilated pupils. And other than the eye muscle paralysis, they often have paralysis of the neck muscle, and they will show this sign, broken neck sign. This is because of the paralysis of the neck muscle. Other than that, some patient might show some symptoms like swallow difficulty, speaking difficulty, or poor respiratory effort because of paralysis of the respiratory muscle. So other than these neurotoxic signs, we need to monitor any cardiovascular abnormalities. So we need to see if the patient is in hypotension, any shock, any cardiac arrhythmic, or any abnormal ECG. So other than the CVS abnormalities, we also look at the renal profile. So we need to see if patient having any AKI. So clinically, we need to see we need to monitor the urine output to see if the patient is having oliguria or anuria, and we need to monitor the urea and creatinine closely. Besides, just now, Adnan also mentioned, besides that the amount of the urine output, we need to monitor the color of the urine also. If, for example, the patient show you a urine bottle with this dark brown urine, it might show myoglobinuria. So this represent that patient is having some rhabdomyolysis ongoing. And otherwise, the systemic envenoming also, we can look for any supporting lab evidence of systemic envenoming. So this is an uncle after a snake bite showing ptosis and some external ophthalmoplegia. So after giving the antivenom, the uncle recovered fully from the ptosis and external ophthalmoplegia. So moving next, this is just now we were talking about the systemic envenoming. So this is the local envenoming. So local envenoming, we look at the bitten side. So if a local swelling involving more than half of the bitten limb within 48 hours, and in absence of tourniquet, that's an indication for antivenom, or the swelling after bites on the digits, especially the fingers and toes, or if there's any rapid extension of the swelling, for example, beyond the wrist or ankle within a few hours of bite on the hands or feet, we need to consider giving antivenoms as well. And there's a parameter we use to monitor the extension of swelling, which can be seen on the right bottom picture here. It is called rate of proximal progression, RPP. So it is a parameter to monitor local inflammation, also determine the progression and severity of local tissue injury. So normally we will monitor in half an hour to 1 hour time. Other than that, we also need to any tender or enlarged lymph node. So any development of an enlarged tender lymph node, we can consider giving antivenom. So the right top picture here showing a gentleman which has a parotic swelling after a Russell Whipper envenomation. So moving on to appropriate antivenoms for venomous land snakes in Malaysia. So these are the antivenoms that we have in Malaysia, and in most of the government hospital, there's always an antivenom available. If the antivenom is out of stock, they normally will get from the closest hospital. Antivenoms are biologics comprising of immunoglobulin molecules or their fragments derived typically from the plasma of animals which have been immunized with the venom. And there are mainly two types of antivenom, which are the monovalent or polyvalent. So by the name itself, we can know that monovalent is just a single species, and normally polyvalent, there's a mixture of venom from different species. So Malaysia depend greatly on the antivenom supply from Thailand, because for the fact that many venomous snakes in Thailand are similar to Malaysia. So the choice of antivenom will be decided by trained who is experienced in management of snake bite. And normally if the snake species identified, the relevant antivenom will be administered. So we can see from the picture here. So the top part we can see from the box of the antivenom. The first one is cobra antivenom, the second one is king cobra, and these are all the monovalent antivenom. And the bottom right, the two is hematopolyvalent snake venom and also neuropolyvalent snake antivenom. So these two are polyvalent antivenom. For the hematopolyvalent, it is for Russell Whipper, green pit whipper, and also Malayan pit whipper. And for the last one, the neuropolyvalent snake snake antivenom is for Malayan creek, banded creek, and also king cobra and cobra. So this choice of antivenom will be decided by the physician who is has experience in managing snake bites. So this is the doses that we have. And other than the land snakes, we also have antivenom for sea snake antivenom. So these two types are the common sea snake that we see in Malaysia. And usually we only have one sea snake antivenom, which is this one shown here. So I'll be showing a video on how to prepare an antivenom. So this video is created based on the CBG guideline on snake bite, and special thanks to Dr. Muhammad Azim, our Houseman coordinator in Hospital UKM, for guidance in this video making. That's end of our presentation. So I would like to welcome our three panelists today. Very thankful for them to join us in this morning on this CNE webinar. So let's welcome Dr. Anas, Dr. Tri Maharani, and Dr. Forhaduddin. So let me introduce Dr. Anas Amri bin Hashim. He's an emergency physician and also emergency physician in Hospital Sultan Abdul Halim, Sultan Sungai Petani, Kedah, and also he's a consultant in RECS, Remote Envenomation Consultancy Services. And he has special interest in emergency medicine, traumatology, clinical toxinology, emergency and critical care ultrasound, and also pediatrics emergency medicine. So the next panelist I will welcome is Dr. Tri Maharani. So she very thankful for her to join us today. So she's an emergency medicine specialist at the Department of Emergency Medicine, and she is the advisor for WHO snakebite, and also the president of Indonesian Toxinology, and also leader policy and program bite and sting animal venomous and toxin plantation. And her special interest is in toxinology, biomedics, disaster, immunology, and also cardiac emergency, and also bioterrorism toxin. Thank you for joining us from Indonesia. And next, we'll welcome Dr. Forhaduddin Hassan from Bangladesh, and he's a consultant in internal medicine in Bangladesh, and also his expertise is in sepsis in low-income and middle-income countries, snakebite management in resource-poor setting, and also conducting high-quality clinical trials in Bangladesh. And also he's a co-author for National Clinical Management Guideline on COVID-19 and snakebite management. Welcome our three panelists today. So we'll start with let's have a few words from our panelists. Let's start with Dr. Anas.
Okay, Assalamualaikum and a very good morning. Can everyone hear my voice?
Yes.
Okay, thank you. First of all, thank you to the organizer, a very wonderful session organized by HUKM, actively involved in promoting and educating all the medical personnel on the clinical toxinology and particularly in snakebite management. So thank you very much. Any questions can post in the chat group as what Prof posted in the chat group. Thank you.
Maybe Dr. Anas can comment what do you think of the presentation this morning? so far?
Okay. First of all, it's very unfortunate because there's quite a number of quite a frequent sounds echo from the presenter. But anyhow, we could hear him presenting. Just the earlier slides, maybe the clinical toxicology. I think what presenter meant was supposed to be clinical toxicology. There's a difference of clinical toxicology and clinical toxicology. In terms of the definition was put, I think supposedly for clinical toxicology. And then the other things, just I could not hear the sounds of the videos played. And then the contents of the presentation, maybe on the local envenomation part, can elaborate more regarding the role of monitoring the rate of proximal progressions, and also the pain score monitoring regarding, it was not I think mentioned there. Other than that, I think it was okay, but maybe you can elaborate more regarding the envenomation parts.
Okay, thank you, Doctor. So next, we'd like to welcome Dr. Tri Maharani. Doctor, do you have any comments or words for the presentation or for the participants?
Yeah, thank you. Good morning. I am very interested with the presentation because toxinology is difficult condition in Indonesia. One, because this area, because the geography of Indonesia difficult to transportation, to telemedicine, and the other. And second, about the antivenom and knowledge doctor and nursing about management of toxinology. I think if these cases, two condition not same with my country, and I know this condition better than my country. If the patient have the condition bed emergency, I think to very easy to deliver to big hospital and helping with the many management, many equipment, many antivenom and the other. So I hope the condition, these cases in presentation better the result with my condition in my country. And I hope the mortality and morbidity not to result in many cases about toxin in other country and my country also. But the limitation in my country, I think must to have many hardworking to my government to helping all the knowledge, the equipment, and the other. Okay, I think now it's enough, but if I have the many idea, I can to ask later. Yeah.
Thank you, Doctor. So next, I'd like to welcome Dr. Forhan. Doctor, any comments for us?
Thank you, Dr. Jia. So first of all, I must want to thank UKM and Professor Khalid to invite me as a panelist. I'm very much privileged to present as a panelist for today's CME. So, and also I must want to give a big thank to Dr. Adnan and Dr. Jia, who has actually presented brilliantly, and the presentation was very good, as well as the content of the presentation, and also the pictures and the demonstrations were very beautiful. And so, but I want to actually point out few points. So first of all, actually, regarding the types of snakes, actually in Bangladesh, we have only 4 big killer, we say cobra, crate, rhesus viper, and also green pit viper, and some very occasional sea snakes. But cobra, crate, and rhesus viper, they are the big killers. But I have seen almost all type of snakes from different families are prevalent in Malaysia. So, and also I have seen a very beautiful book on land snake of Malaysia. We hope that in Bangladesh we can write similar books for Bangladeshi clinical researcher or herpetologists. Regarding the other parts of presentation, so I wanted to point out a few other areas. Say, whenever you are bringing some images or any factual information, you need to give references, and as well as for the images, the presenter could give credit to the photographer or any other books or any sort of copyright. I don't know whether the team has collected the photo from any book or any researcher personally photographed that images from patients. I have no other observations. Just I wanted to differentiate few other points. Like in Bangladesh, actually we have only polyvenom and antivenom, and we usually import the antivenom from India because we don't have any local antivenom production. But currently we have Bangladesh government has formed a venom research center in Chittagong Medical College Hospital, and we are now collecting all sort of snakes of different species which are prevalent in Bangladesh, and we are trying to prepare our own antivenom, and with the collaboration of university in Germany. And just I have one worry to the presenters. So do you actually give adrenaline as pre-medication before administering antivenom, or you just give an adrenaline whenever patient develops any anaphylaxis or not?
We will prepare the adrenaline before administer of the antivenom, and we will be anticipating if there's any anaphylactic shock, and if there's any sign of anaphylactic shock, we'll be administer the adrenaline. If not, we will not.
Okay, so as pre-medication, do you give subcutaneously or intramuscular?
There's no pre-medication given.
Okay, okay. So we have actually, I don't know what is the anaphylaxis rate of antivenom in Malaysia, but we do report lots of anaphylaxis report here in Bangladesh. That's why in national guideline we have incorporated to introduce subcutaneous adrenaline before administering antivenom. And it actually, though this is, we haven't yet any randomized clinical trial on that, but still as an observation, we have found that the rate of developing anaphylaxis has reduced down dramatically after receiving the pre-medication and adrenaline as pre-medication. Okay, thank you very much. This is all from my side. I can join other later on in wider discussion, actually.
Okay, so thank you so much to all panelists. So maybe our moderators we can start the question and answer forum with all the panelists to join us, to turn on their camera. So do we have any questions perhaps from the moderators to ask, to put forward? I think the issue about the, it's not an issue, the practice of giving a pre-medication with subcutaneous adrenaline will depend on the type of antivenom that you use, which part of the world you are in, and what is the justification for such a practice. So in Malaysia, we, as our moderator, our presenter showed, we are using antivenom from Thailand. We do not manufacture antivenom in Malaysia. So from our experience, the rate of anaphylaxis is not the rate of reaction. The rate of anaphylaxis is rather low, in the realm of less than 10%. And those are the practice that we use, is to treat as the anaphylaxis develop rather than as a pre-medication. But in terms of reaction, we have a higher percentage of reaction in terms of just skin rash or itchiness, very mild reaction, which we can treat easily with antihistamines and also what do you call this? Some steroids on board as well. But those are actually doesn't really stop the giving of antivenom to patient. So we still give antivenom. Either we withhold the antivenom until the reaction resolve, or we still can continue at a slower rate after giving the medications for combating the reaction. But in terms of anaphylactic shock, obviously we will have to withhold, and that's where IM adrenaline. So it's IM adrenaline rather than subcutaneous adrenaline earlier, as mentioned by Prof. Forhad. So we give IM adrenaline, and after second or third trial, if it's still in not responding, we can already continue with intravenous infusion of adrenaline as well, diluted, of course. Okay, so what do you think about that, Dr. Anas? Have we experienced a lot of reaction from Malaysian side?
Yeah, I think from our REX consultation that we encountered, it's not as a spot free. I think less than 20% that we encountered. Even personally, from my experience, giving antivenom is not that much. I think in Malaysia, what we do at the first 5 to 10 minutes, we usually infuse at a slower rate, maybe 1 to 2 ml per minute, rather than straight away over 1 hour. I mean, upper 10 to 20 over 1 hour. We try to slower it, and then if there's no reaction at all, then we try to aim to finish within the 1 hour periods. So we no longer giving a subcutaneous test dose of antivenoms, and we also do not prophylactically give adrenaline for all patients who receive antivenoms. If they've developed the actions or anaphylaxis, then only we give adrenaline. If, like Prof said, if milder form of allergic reaction, then we only come treated with steroids and antihistamine. Yeah. I think another thing also down to the preparations of antivenom. The method of preparation, dilutions also do contribute to the allergic reaction, I would say. Yeah.
What about Dr. Maha, Indonesia? Do you have encountered a lot of allergic or hypersensitivity reaction or anaphylaxis for antivenom that you use in Indonesia?
Yeah, you know, Dr. Khaldun, because antivenom Indonesia, Biosafe from Biosarma, not hypoallergic. And you know, many cases, I have many cases in my last hospital. Every month I have cases about allergic from my antivenom Biosafe, and give this corticosteroid. And I have one cases anaphylaxis. I gave adrenaline also. And if after management of the allergic until anaphylaxis, I must give again this antivenom because patient must need this antivenom to bind this venom. And you know, my antivenom Indonesia production covered 3 snake, cobra, Najas putatic, Java cobra, yeah, and Bungarus fasciatus and Caleslasma rhodostoma. But Bungarus candidus and Naja sumatrana, because we don't have this antivenom, and you know this antivenom from the Thailand, I buy now with my government. I think since 2000 last year, we buy many antivenom from the Bangkok, not covered. Naja, not covered Bungarus fasciat, Bungarus candidus, and and Naja sumatrana in the one file. I must buy monovalent Bungarus candidus, and I must buy Neuropoly Bungarus candidus, King Cobra, and the other. You know this production, and now I asked to many doctor and asked to many cases, because you know the geographic Indonesia, same Asia, and part is Indonesia, same Australia, and Wales area, not same Australia on Asia. It's difficult to management snake bite. We have the policy to give this antivenom and give knowledge to the doctor to observation about this allergic until anaphylaxis, because many cases not dead about this envenomation, but about the anaphylaxis. I am afraid doc. You know, my country is very big, and this case is snake bite very high also. If the death about this knowledge, no knowledge about anaphylaxis, I think it's very difficult to my doctor and my colleagues. Okay.
Yeah. So so maybe Dr. Forhad, where do you produce antivenom in Bangladesh, or you have to import, or how do you, how does it work?
Thanks. So we do import polyvalent antivenom from India. They actually produce a polyvalent antivenom containing SB against 4 big killers of India, like common braid, cobra, Russell's viper, and soy scaled viper. But in Bangladesh, actually, soy scaled viper is not prevalent. But very recently, we are increasingly reporting a good number of cases of Russell's viper. But unfortunately, that polyvalent antivenom does not work against Russell's viper. I don't know why. There might be some difference in venom of Russell's viper prevalent in Bangladesh and in India. And so we are in preclinical stages of developing antivenom, just collecting different types of snakes from all districts of Bangladesh, and extracting venom, and just characterization of venom, and some preclinical studies, which actually I'm not that much aware of, but that's going on with the collaboration of a German university. So after that, they will prepare some monovalent antivenom against cobra and braid at first, then against some other snake like green viper and Russell's viper. In Bangladesh, we report lots of green viper bites, but we don't have any antivenom for that. Even with government does not import antivenom from Thailand or India for the green pit vipers. We just treat supportively with fresh poison plasma or blood transfusion if required.
Yeah, so I mean, you brought me to the snakes center before in Bangladesh. we visited that place, so it was very interesting. At that time, it was still just developing. So I'm happy to hear that it's actually working towards actually achieving the antivenom production in the near future. But it's interesting that you mentioned about preclinical. So do you do the preclinical testing for antivenom when from India as well when you import them to see if it works for your species?
No, actually, now both antivenoms are being characterized and being tested preclinically in abroad, not in Bangladesh, because we don't have that facility. We are now trying to collaborate some local universities like Chittagong University. There is a geology department and another researcher, venom researcher from different university, which is called Rajshahi University, a scientist. So they don't have that much capability to do all sort of venom preclinical level venom research facilities. That's why we have a big collaboration. I just forgot the name of the university from Germany. So they are actually, do you know Professor David Warren?
No, not personally.
Okay, so he is a kind of very big authority in snakebite management of WHO. He is collaborating that project with.
Okay. Right. So I mean, just to give you an example as well. So how we can help our colleagues in the region. For example, the Philippines had develops one antivenom for their cobra, and they want to know whether that antivenom can also neutralize the venoms from other cobras. So in the Philippines, they have 3 different species of cobra and 1 king cobra. So they only made the antivenom from 1 species of cobra. So what we did was we extend our expertise from Malaysia. One of our colleagues, laboratory for venom and toxins in University Malaya. So they collaborate and they help our Philippine colleagues to see to do that preclinical testing, and they found that there are some cross neutralization properties of that particular venom and that particular antivenom for the other cobras in their country. So they can be used, but obviously for different species of cobra, other than that particular cobra that used to make antivenom, the efficacy is slightly lower, which translates into being possibly requiring more vials, more amount of antivenom to neutralize completely the venom from the other species. So I'm not sure how far you are from India, where the antivenom, the polyvalent, was made. But even I think from my understanding of my recent my reading as well, there appears to be some differences in terms of efficacy from where the Indian polyvalent was made and sampled throughout the whole India. So not doesn't mean that it is the same efficacy for everywhere in India, even for the same species. So geographical distribution, because India is quite big as well, so it's quite far. So they may be the same species, but the venom composition is probably different, and therefore the efficacy from the sampling of the venom for the antivenom production may not neutralize as efficient as from where the snake venom was sourced. So that is a very interesting. So what I'm trying to say here is, I think maybe as you said, cooperation and building networking with other capabilities, those that can help you with analyzing is actually going to be very fruitful as well. So well done about that. So anyway, do we have any other questions or any our moderator, Jawan?
We have one question from the participants. So, Amir asks, in the event of envenomation of a non-native or exotic species in Malaysia, which party is usually involved in the process of outsourcing the antivenom? Is it the IECS or the National Poison Center?
Okay, maybe Dr. Anas want to respond to this.
Okay, I think like it was it last year? Last year we had a case of an envenoming from the, I think, puff adder, foreigner. I think they brought in the snakes. So it's obviously the snake is non-indigenous in Malaysia, and we don't have that antivenom for it. I think the only place that we found was from the Singapore zoo. I think we got it from the Singapore. So I think it was a collaboration between Rex, was consulted by the Rex consultant. So we liaised with the KKM people and also from the university, I think HUKM people, because the patient was brought into I think PPUKM. So I think it needs several authorities, but I'm not sure about the financial, the costing part. Maybe Prof can highlight on that. But yes, if we do get envenoming, bitten from the non-indigenous species, we try to find the nearby center that can provide the antivenom, especially from Singapore or other parts that can send we can get. Yeah. But from the resources financially, who pay that one, I think maybe Prof knows better.
Yeah. That's the good point that Dr. Anas was saying, that let's say if you have an exotic snake, who will pay for that antivenom if we do get them? So that's the thing about Malaysia. The policy is that we do not keep or procure antivenom which not for local species of snakes. So at the moment, in terms of procurement, the Ministry of Health only has the obligation to get the antivenom for the local species. So that's where we get our antivenom from Thailand. And also we know that for the sea snake is from Australia. But for the other species that comes, what we term as exotic or non-national snake, we don't really have that obligation to procure. But in terms of humanitarian, this is a humanitarian effort to even help, even though we know that case is illegally brought in or improperly brought in, then we still try to get some sort of resource. So what we did was because of our networking as well in the region, we know that Thailand had previously import some exotic snakes, including the Gabon viper, and they brought in along with them the antivenom for that pit viper or for that viper. Similarly, within Singapore, in the Singapore Zoo, they brought in or import or they have pit viper from a viper from Africa, and they brought in as well the antivenom for that. So that is very responsible thing to do for their part. But since we do not have the official things about this in Malaysia, we just ask for their assistance, whether we can actually get their antivenom and perhaps then either replace or pay back to them the cost. So this is at the moment what we did for that case. The puff adder is the owner of the snake has agreed to take up the burden of the cost of the antivenom, and also arrange for the antivenom to get it from Singapore. So he agreed to arrange his flight, to arrange the collection and also the payment to Singapore Zoo. So and we had a very good help, excellent help from our colleagues in Singapore Zoo to bring the antivenom to the airport for the person to collect. And at the same time, we also had because it's a medical drugs, right? So when we import, we have to have some sort of permit. So we had a good connection also with KKM in the Ministry of Health to provide us with the permit to bring in the antivenom. All these things are going on at the same time while managing the patient. So obviously, it takes a lot of time. And there's no real obligation for our colleagues in Singapore or in Thailand to provide us the antivenom because it's meant for their own use, not for our use. But because of humanitarian concern or consideration, we managed to establish that kind of assistance. But unfortunately, for that case of diabetes eritans, because of the time and the severity of the envenoming, the patient died before the antivenom could reach us. So it's a bit sad. But bringing on to the next point is discussion is how is it then the law or our regulations in dealing with such a case of exotic animal or exotic snake by envenomation. So this really need to be looked at so that let's say, for example, somebody wants to bring in this exotic or dangerous venomous animal, they must also consider bringing in or import the same antivenom for that particular animal and liaise with the hospital or nearby healthcare facility to keep and to administer the antivenom. So we did this exercise with Thailand before when Siam Serpentarium opened and brought in exotic snakes, venomous snakes, and we advised them what antivenom to bring in, and we liaise with the hospital that if any of the workers in that Siam Serpentarium got bitten by this exotic snake, there's one hospital which they can go to, which knows the antivenom for that particular snakes, and they are keeping the antivenom in that hospital. It's a private hospital, but they managed to liaise with the zoo. So that kind of, I think, consideration needs to be looked at and also try to polish up in our Wildlife Act, for example, or Animal Act in Malaysia. I'm not sure what is the situation with exotic animal or venomous animal in Bangladesh and Indonesia. Maybe Dr. Forhad would like to comment. Since you are in Abu Dhabi or Dubai, maybe you are bringing back some pet snakes, venomous to Bangladesh.
Yeah, I'm not really aware about whether we have any sort of policy planning for the exotic snakes. We have some exotic snakes in zoo, but haven't really reported any bites in zoo. I'm not actually much aware about that. But this should be because the number of zoos are increasing, and also zoo authority, they try to collect different types of snakes which are not prevalent in Bangladesh. So there is a big possibility to increase in the incidence of snake bite. Yeah. And
what about Dr.
collaboration you have?
Yeah. Go ahead.
Yeah. So for the collaboration about the preclinical studies, I must contact with Professor Joy, and we'll let him know about your sort of intention in extending the collaboration from Malaysia side.
Oh, lovely.
It'd be a great opportunity for us to explore the future collaboration.
Our colleagues in the toxinology research, toxinology will be happy, I think, to entertain that.
Sure.
Yeah, they'll be good. So what about Indonesia? Dr. Maha is still with us? Do you have a lot of exotic venomous snakes in, people keeping exotic animal for pet or, for entertainment?
Indonesia has many exotic animals, and we have many community of reptiles. Last month I have cases And I think you know this person because if you go to Indonesia, he come to this training and Biade. He has the education with the I think Bomba in Malaysia name ya, in Indonesia name Tim Star and BPPG.
Yeah, fire and rescue. Yeah.
Yes, fire and rescue. And this cases, this man, the king cobra angry with him, I think, because uh, you know this king cobra not little but very big, for 4 meter until 5 meter, and beaten this man. And because I go to Turkey to team emergency, and I have time to send this anti-venom monovalent king cobra. I send this hospital in Borneo in Kalimantan, the South Kalimantan. But I think this condition not okay, and this man dead about it. And you know, the exotic animal in Indonesia, uh, very variation this snake. And you know, because the many people don't know this good first aid, and many incident about it fatality, not go fast to the hospital, but go to the uh, traditional healer, dukun, and with many treatment with self, uh, many cases mortality and morbidity. And now, you know, I make this law about it. I asked to my government to make an Indonesian name Permenkes, the law about the seller, about the attraction, and about the hobbies. Because this cases mortality and morbidity in Indonesia about it. At 10 here, many cases and many mortality. This year, only 3 months, I have over than 10 cases and 3 cases mortality, doctor. Yeah, if you come to Indonesia, I must you meet to my Minister of Health because this law is very important to my country, doctor. Yeah.
Yeah, but those
Yeah,
are those are local snakes, right? So local snakes.
yeah,
So I know there are exotic snake. Exotic means that the snake is not from Indonesia.
yeah.
They're not local species. I've seen in social media and so on showing keeping rattlesnake. Rattlesnake is
Yeah.
not Indonesian. Rattlesnake is
Yeah,
American.
but many rattlesnake in my country, you know, in
Yes, and
Jogja.
yeah, and it becomes a central where they export this locally breed or locally what do you call uh grown rattlesnakes to other people in the region who is interested in the species. So that is very dangerous. It may not come from the US, but it comes from the pet trade, which from the country in this region. But the animal that they grow or they produce is not originally local in per se, though it was born in that country, doesn't make it
Yeah,
Indonesian or doesn't make it Malaysian or Thai, you know. So because that has a consequences in terms of, let's say, for example, import permit and so on. They don't need to import because it's
yeah,
already born there, but still we do not produce the antivenom for that species in our country. So that caused a big problem when someone got bitten by this so-called local exotic snakes, you know.
yeah.
Yeah.
I think it's
So
very
anyway,
difficult
that's very
to
interesting.
handle it.
Yeah. So that's very interesting. A bit of a headache now. We hope that's where our wildlife department, some of part our ministry can also help
Yeah,
to tackle this issue because they may not be aware that there is a problem. So we have to tell them there is these issues of people bringing exotic snakes, not just snakes. We have encountered scorpions, which are non-Malaysian, which is also very dangerous. Some people brought in piranhas, which are, to keep in the aquarium, all kinds of so-called exotic animals. And they are not just beautiful, but they are deadly as well. So that is another
Yeah,
issue
definitely.
that people
I
have to
agree
be
with you.
aware.
Definitely.
Yes, yes. Okay, so do we have any other questions, our moderator? Do you have any question to perhaps bring into the discussion?
Thank you, Prof, and the panelists for the very informative and very interesting discussion. So far, we don't have any more questions from the floor. And shall we proceed to the quiz?
Yeah, it's up to you.
Okay, let's proceed to the quiz. We'll start the quiz now. So before we ending this session, these are the references that we use in making this CME webinar. Otherwise, I would like to share another instructional video competition, which will be held later at 2:30 p.m. in Zoom link. So let's watch the video. So everyone is welcome to join the instructional video competition, which will be held at 2:30 p.m. later at Zoom. So that's all. Thank you all for coming to the CME webinar. So the QR code on the right side is for feedback and e-certificate, and the link is already inside the comment box. And otherwise, the left side is for the CPD point. For the CPD point, you need to scan via the app MMA CPD. Thank you, Prof. Khaldun, and thank you all the panelists, and thank you for all the participants for joining us this morning.